and welcome to the latest ECIST podcast. My name is Pete Gordon. I'm Head of Emergency Care Improvement with ECIST, the Emergency Care Improvement Support Team. I'm joined by my colleagues, Ben and Richard. Ben, would you like to introduce yourself?
Yeah, my name is Ben Owens. I am an ED consultant for Sherwood Forest. I'm an ECIST clinical associate.
And Richard?
Hi, I'm Richard Genever. I'm a consultant physician and geriatrician at Chesterfield Royal Hospital, and I'm also an ECIST clinical associate.
Brilliant. So today in this brief podcast, we're going to talk about clinical early discharge. So Richard and Ben are going to have a conversation and thinking about those patients who no longer need to be in hospital, but need some form of further clinical input. So if we start with you, Ben, what are your initial thoughts?
Yeah, well, if we look at patients in hospital beds, they often need admitting because they're clinically unwell and require hospital treatment. And there's a subgroup of those patients who, after their initial illness, either have a secondary problem that's there that perhaps needs additional. They come in with a pneumonia and it turns out they might have lung cancer and so that's being investigated. But actually that potentially could be done as an outpatient. Or there are people who come in with an illness who an AKI2, for example, who come in and actually after a period of time they're recovering, they're getting better, and actually you want to make sure they're getting better. So you either keep them in until their usual needs are completely resolved, or could we do something different when they're getting better to send them home and somehow recheck their tests in another way? Another group of people, example, would be someone who comes in with shortness of breath, infection, possible heart failure, and actually they're waiting for an echo, which might on a Friday, the echo's going to occur on a Monday. They're going to stay in hospital for 2 days. Not much is going to happen to them, but actually, how could that be facilitated differently, I suppose? And how do we get those people? Because actually, when they're in hospital, they're at risk. They're at risk of non-scopal infection, deconditioning. They may get their care package stood down, all sorts of things that aren't great for that patient. And obviously, it adds risk and stress to the system. So that's the sort of thought process of the patient groups we're talking about. And we had some ideas about what we could do, how we could utilise stuff we've already got for this winter. And Richard, what are your thoughts on that?
Yeah, I'd certainly say, look at what services are already in place, because there may well be things that are there within your organisation that aren't fully utilised. So, for instance, you may well have a mechanism for organising tests that could happen very quickly following a discharge. There may well be, particularly if these things are picked up early, ways of following it up through, either an SDEC or something similar to that, depending on what's in place. Some places also have got virtual wards set up already, which allow a way of tracking these patients. Because when you think about the obstacles to discharge, there's probably three main things that people worry about. One is they may not feel there is an outlet for that person, no way of following up. Perhaps you don't have a clinic of your own. The second thing is perhaps a fear about not wanting to lose track of what's happening with a patient. A situation that's currently under control, if left, might become a more serious situation, and fear that may not happen. And then the third one, I guess, is an anxiety about potentially creating much more work for yourself down the line. So if there are things in place already that would help you to address those three fears, then that's going to make it much more likely that you're going to make the decision to be able to still act on the things. We're not saying to ignore problems that require follow-up, but think about whether hospital is the best place to follow that up.
Brilliant. Yeah. And just asking both of you, have you got some sort of actual sort of clinical examples you could possibly talk through?
Yeah, sure. I mean, a couple of quick. So if I see a patient in ED, for example, who comes in retention, they'll be catheterised, we'll check their bloods, we may start them on some brief medication, they'll be sent home and they'll have a TWOC in the community and urology follow-up as an outpatient. That's a really common presentation to ED and to hospitals all over the country. What I observe is if someone in a medical ward comes in and they go into retention, what happens is they get catheterised, and quite often they're then kept in until there's an attempt to take the catheter out in a few days' time, and they wait for your inpatient urology opinion, and actually the patient may have completed their acute episode. So actually allowing your inpatient teams to refer into your outpatient pathways, and also making them aware of it. So yeah, we thought about, could we have a DOS available so all, as Richard says, all the existing pathways you have that the ED knows about, or geriatrics knows about, or urology knows about, and share them, and then share them with your site teams, with your junior doctors, with your on your intranet, with your other teams, to allow access for everyone from those things. And the other obvious example from a surgical one would be there's an outpatient DVT pathway. Someone who comes in has an operation on their abdomen, they're ready to go home, swollen leg, they're going to be kept in for an ultrasound Doppler. Actually, why not send them home and plug them into your outpatient DVT pathway? They're just two examples, and there are many out there. Richard?
Yeah, so I've come across a situation recently where a patient was kept in for an MRI scan of their brain, and it was a legitimate test. It was thought that they might have had a small stroke, and they ended up staying in over a weekend. They had the scan was normal, and off they went. But actually, during that time, they didn't receive any inpatient care. It was really all about feeling that this was the best way to get the scan. And of course, when people have outpatient tests as an inpatient, it can create all sorts of problems. So there's the problem for the person themselves who's kept in hospital when they don't need to be. But actually, for the people who are already awaiting a scan, if somebody has a test done urgently, what often happens is somebody else who was already on that waiting list will actually be pushed off and have to be reappointed. So there can potentially be a harm that comes to that person. The other thing that often happens as well is that all test requests are triaged by radiology, and if the test is felt to be important but not urgent, actually it will probably happen several days down the line on an inpatient, and could be done just as quickly as an outpatient. And it's another situation where the pathway already exists in most places to get the test done quickly, probably just as quickly if the person's discharged. It's just thinking about it, really.
Thanks, Richard. One thing we talked about was, so pathways exist, so 2-week wait pathways. So someone comes in with a problem, they may have cancer. Actually, well, what would stop them being discharged to a 2-week wait pathway? Even as a follow-up one, if the scans are arrange a CT chest, abdomen, pelvis, discharge the patient, put them in a follow-up appointment for that is one example. If it's MRI head's a good example. If there isn't a neurosurgical department in your hospital, then plug them into your ambulatory care, ECIST, medical day case. What other pathway could you utilise? I think the other thing is to bring it back to the patient is these days, particularly when there's no visitors allowed in hospitals, or particularly people worried about cancer and other things, actually being in hospital when you can't have visitors in those times is really distressing for them. So it's not just the risk of being in hospital, actually just being stuck in hospital all weekend is something that they don't want and can be difficult for them. And the other thing I think around the tests is perhaps an agreement. If someone is discharged, if a patient's an inpatient and you agree they need an MRI head in the next 2 or 3 days, what you want is almost an agreement. If I discharge this patient, it's the confidence that they won't go, oh, it's not an inpatient scan anymore. Well, that we can bomb that down the line. So some of the things about this is the agreement with the diagnostic services, the echoes, that if this patient is discharged to an outpatient setting or to an ECIST setting, they'll still get their scan in a timely fashion, because it's really important people have confidence in this process.
Thinking about your final thoughts around summaries around clinical early discharge, what are some of your key messages for frontline clinical teams out there, practical stuff that they can do, thinking about this winter and beyond?
Cool. So the question, a good test for I think if you're on a ward is, if the patient's well enough to wait for something, 2 or 3 days, does it really need to be done as an inpatient? Could they be sent away and brought back? What could you do? Can you use your virtual ward? Can you ask ECIST? Can you ask if this could be done through your site meeting? Is there a pathway for this? And actually think about, could I utilise another specialty, rather than saying I want you to come and see the patient, just how can I follow this patient up? So we often say, I want an opinion from this specialty. Actually going, they've got a secondary problem, how do I get them followed up as an outpatient, rather than can you come and see them as an inpatient? And they'll probably go, oh great, yes, there's a clinic for this or a pathway for this. So utilise your networks and things in the best way, and just think, if the patient's well enough to wait for it, can I do this in a different way? Because it may well be better for them.
Brilliant. Richard?
Yeah, I would agree with all of that. I would say try and keep things simple. Start with the services you've already got, rather than trying to rapidly pop up services that perhaps are ill thought through. talk to clinicians about what do they perceive as the obstacles to discharging people, because that will allow you to try and target what you do in a way that feels like it's going to be beneficial. So think about, is it concerns about losing track of patients? Well, then it would be fairly easy to set up a virtual monitoring system or a virtual ward or something like that. Is it something about workload? So there may well be the pathways that Ben has talked about that actually take care of a lot of that. So address what the concerns are by the clinicians. That way you can talk about the things that are most likely to help, but above all, just really keep it very simple.
Brilliant. So we've come to the end of our podcast around clinical early discharge. Huge thanks to Ben and Richard, two of our brilliant clinicians, and we look forward to seeing you again. Thank you very much.